Welcome to this learning module on two crucial aspects of mechanical ventilation: positive end expiratory pressure, PEEP, and the fraction of inspired oxygen, FIO2. PEEP and FIO2 are part of the backbone of managing patients on mechanical ventilation, and in this module, we'll delve deeper into their significance and application. Before we proceed, let's recap the key points from our previous lesson. We explored the breath cycle, inspiratory time, and inspiratory to expiratory ratio, and introduced the flow waveform. These concepts help form the foundation of our understanding of mechanical ventilation. The breath cycle initiates with the start of inspiration and concludes with the end of expiration. The ventilator delivers a specific number of breaths per minute, known as the frequency. The time in seconds when the ventilator delivers a complete breath is the inspiratory time, or I time. The inspiratory to expiratory ratio, which is the proportion of time spent inhaling to the time allocated for exhalation during one breath cycle, is influenced by the frequency and I time. Adjusting these link controls in mechanical ventilation is crucial to address the patient's clinical pathophysiology, facilitate ventilator synchrony, and ensure patient safety and comfort. Flow, measured in liters per minute, refers to the rate at which the ventilator delivers a volume of gas to a patient during inspiration and the rate at which air exits during the expiratory phase of the breath cycle. The vertical axis indicates flow and the horizontal axis depicts the time in seconds. The middle line in the graph, labeled 0, separates inspiration from exhalation and is the no flow line. The waveform above zero flow visually denotes inhalation and exhalation below it. At the end of exhalation, the flow waveform should return to the no flow zone until the patient or ventilator triggers the next breath. Let's dive deeper into what we learn about our patient's ventilation status by examining the flow waveform. Suppose the expiratory branch of the flow waveform does not return to the zero flow line before the next breath. It indicates breath stacking, a harmful and potentially lethal condition we must correct. Here is a patient with emphysema, Wheezy McGee, intubated for failure of oxygenation and ventilation, and his anticipated clinical course. Here are his initial ventilator settings. Initially, he has a frequency of 20 and an inspiratory time of 1 second, yielding an inspiratory to expiratory ratio of 1:2. Poor obstructed Wheezy only has 2 seconds to eliminate 450 milliliters passively. Take a look at the flow waveform here. It does not return to zero before the ventilator delivers the next breath. You can see that 450 milliliters is going in, but only 399 milliliters exits the chest before the next breath is on its way in. This incomplete exhalation eventually leads to pulmonary hyperinflation, alveolar injury, and worse patient outcomes. Patients with advanced COPD have highly compliant lungs that lack recoil and harbor underlying obstructive pathology. If the lungs have minimal elasticity and constricted airways, breathing in and especially out will be challenging. How can we set the I time, inspiratory to expiratory ratio, frequency, and tidal volume for best results? First, let's figure out Wheezy's ideal body weight. He's 60 inches tall, yielding an ideal body weight of 50 kilograms. Since Mr. McGee's lungs have the recoil of a plastic shopping bag, the tidal volume of 450 milliliters per breath, or 9 milliliters per kilogram, is acceptable. What else can I do to address Wheezy's pathology besides inhaled bronchodilators, IV steroids, and beta agonists? I can change other ventilator settings. The breath rate is too fast. A frequency of 20 shortens the time for expiration, and old obstructed Wheezy needs more time to exhale. After setting the breath rate to lucky 13, I adjusted the inspiratory time to 0.85 seconds, generating an inspiratory to expiratory ratio of 1 to 4.4. These new settings give Wheezy McGee about 3.75 seconds to exhale his 450 milliliter tidal volume passively. Let's see if the medical management and adjustments to the breath rate, I time, and inspiratory to expiratory ratio had the desired effect. Yes, the vitals are stable, the measured gas volume in and out is the same, and the flow waveform returns to zero flow before the ventilator delivers its next breath. Rest assured, adjusting PEEP and FIO2 is not just a safe way, but the most effective way to maintain optimal oxygenation in your patients. Like peas and carrots, positive end expiratory pressure and the fraction of inspired oxygen go together when we think about oxygenating a patient. PEEP refers to the pressure in the lungs maintained at the end of expiration. You can see the PEEP of 5 centimeters of water pressure on this pressure waveform. The waveform does not return to zero due to the positive end expiratory pressure. PEEP keeps gas in the alveoli at the end of expiration, precludes atelectasis, improves the functional residual capacity, and helps to retain a larger surface area for gas exchange. The PEEP facilitates alveolar recruitment. The supplemental oxygen has an opportunity to diffuse in, and CO2 can exit. Collapsed alveoli cannot exchange gases. Therefore, keep PEEP and supplemental oxygen married in mind. The fraction of inspired oxygen, FIO2, is the percent of oxygen in the gas mixture the ventilator delivers. You may see FIO2 articulated as a percent or expressed as a decimal. For example, an FIO2 of 0.5 or 0.50 equals 50%. An FIO2 of 0.65 equals 65%. And an FIO2 of 1 is 100%. On the Hamilton T1, dialing in the amount of oxygen is easy. Remember that the higher the FIO2, the faster the oxygen bottle is consumed. Patients do not tolerate hypoxemia well. Generally, we correct hypoxemia by adjusting the FIO2, beginning at 100% with a close eye on the pulse oximeter. As we titrate the oxygen percentage down, we aim to use the least amount of oxygen and the least amount of PEEP to correct hypoxia, as evidenced by a saturation between 94 and 99%. Prolonged oxygen toxicity is harmful. It causes an inflammatory response, vasoconstriction, and lung damage. It can exacerbate tissue damage and contribute to acute respiratory distress syndrome. PEEP can cause barotrauma due to overdistension of the alveoli. It can also decrease cardiac output because at higher levels, it may increase intrathoracic pressure, reducing venous return to the heart.